Good morning, good afternoon, and good evening to everyone. Welcome to Asian Society of Pediatric Anesthesiologists Cardiac Special Interest Group Forum. It is my great honor to be the moderator of this webinar since we have three very precious speakers. Our meeting today is about challenges in intensive care unit after cardiac surgery, part 1. I want to introduce myself. I am Dilek Altun from Turkey, Associate Professor working in Acıbadem University. My interests are pediatric anesthesia, pediatric and adult cardiac anesthesia and intensive care unit, pain management, difficult airway management, and difficult vascular access. Today, Dr. Tao will be us as a co-moderator from Vietnam. Dr. Tao Jiang will our co-moderator from Vietnam. She is working in National Children's Hospital. Her interests are pediatric cardiac anesthesia and lung ultrasound, protective lung strategy in minimally invasive cardiac surgery. Please, Dr. Tao.
Thank you, Professor Dalek. I'm very honored to be here. And we are the Cardiac Scientific Interest Group of the ASPA. We try to create the platform to share insight and expertise with the vision of improving standard of pediatric care in the region. And today we will have the challenge in ICU after cardiac surgery part 1. And here you can scan the QR code to sign up with the cardiac SIG. We will have three speakers, very precious speaker today. Associate Professor Omar Farag will talk about us with the post-op ventilation strategy in the congenital heart surgery. And we will have Professor Shana Ayabakan with the topic of arrhythmia in ICU after cardiac surgery. And we will have Professor Danis Sukov with the topic of persistent pulmonary hypertension of the newborn. So please enjoy. And during the webinar, you can ask questions or share your comment. Please use the Q&A function. The chat and raise hand function are disabled, and our moderator will highlight your question to the appropriate speaker during panel discussion. Some questions will be answered by text, so please check the chat box by the appropriate speaker in the Q&A box. And we will do the polling. When the poll is launched, you will be prompt to answer the polling question within 30 seconds. And we will set the result soon after we end the poll. After the result is shared, you may close the poll so that you can see the slides by our speakers. And we give the certificate of attendance. So please scan the QR code at the end of the session to access the MCQ and survey form. And the certificate of attendance will be forwarded to those who successfully submit the MCQ and post-webinar survey. Please ensure that you have correct key in your full name and your email address. And we have a three platform. The website aspa2000.com, and we are available on Facebook and YouTube. You can always replay all of our video recorded on the YouTube at the ASPA flag. So please visit, like, and follow us. And now we will come to the polling question number 1 regarding to our next, the first presentation. Ventilation strategy play a role in hemodynamic process in the patient with a congenital heart disease. Number 1, true. Number 2, false. You have 30 seconds. And the time is up. Yeah, you have 100 true. So the true answer is 1 true.
I want to introduce our first speaker, Associated Professor Ömer Faruk Şavluk from Turkey. He's working in Health Sciences University Department of Anesthesiology and Reanimation. His interests are pediatric cardiac anesthesia and intensive care unit, extracorporeal membrane oxygenation, and transesophageal echocardiography. Please, Şavlık, it's your turn now.
Thank you very much, Dr. Dilek and Dr. Tao, and thanks for asking me to participate in this very challenging webinar about challenge in ICU after cardiac surgery. So anyway, today I'm supposed to share with you all about postoperative ventilation strategies in congenital heart surgery. In this presentation, before we move on, I want to divide this presentation in two parts, and I'm going to talk about on cardiopulmonary interaction with and without positive pressure ventilation, and in the second step, I will try to talk about approach the mechanical ventilation for postoperative congenital heart surgery. And as you know, the heart and lung work strictly interaction to supply oxygen to be consumed by various tissue. And heart-lung interaction, the greatest determinants of hemodynamic response to an increased lung volume are mechanical in nature. Since lung volume increases with the application of positive airway pressure, the diaphragm is pushed down and the two expanded lungs, this thus increasing the pressure surrounding the heart. As such, the juxtacardiac interthoracic pressure is greater than the interthoracic pressure at the lateral or diaphragmatic chest valves. This increase in interthoracic pressure is disadvantageous to the ventricular filling. Therefore, extreme pulmonary volume can impair ventricular filling to the point of creating a tamponade physiology. So, mechanical ventilation and spontaneous breathing cause change in intrapleural or interthoracic pressure and can independently influence key determinants of cardiocirculatory performance. Atrial filling or preload, impedance to left ventricular ejection or afterload, contractility and heart rate are all affected. Spontaneous inspiration causes a negative pleural pressure and the reduction in intrathoracic pressure significantly influences venous return to the right atrium. In contrast, post-pressure ventilation causes an inspiratory increase in the intrapleural pressure. You know, venous return is the main determinant of cardiac output and is dependent on the pressure gradient between extrathoracic veins and right atrium. Spontaneous inspiration increases this gradient, thus increasing the venous return. As such, right ventricular preload and stroke volume increase during spontaneous breathing or during negative pressure ventilation. But the opposite occurs during post-pressure ventilation. An increase in mean intrathoracic pressure during post-pressure ventilation decreases preload to both pulmonary and systemic ventricle, but it has opposite effect on afterload to the ventricles. Actually, changes in lung volume have a major effects on pulmonary vascular resistance. Then an increase in pulmonary vascular resistance increases the afterload or wall stress on the right ventricle, and compromising right ventricular function and contributing to decreased left ventricular compliance secondary to interventricular septal shift. In addition to low cardiac output, sign of right ventricular dysfunction, for example, tricuspid regurgitation, hypotomegaly, acute pleural effusion, may be observed. An increase in mean intrathoracic pressure increases the afterload on the right ventricle from direct compression of extraalveolar and alveolar pulmonary vessels. So let's make it simple. There are four mechanisms that summarize some good heart-lung interaction. When you increase this increases pleural pressure, what you have a decrease in right ventricular ejection and eventually will lead to left ventricular preload and left ventricular ejection. Conversely, when you increase transpulmonary pressure, you will increase right ventricular afterload, but you decrease left ventricular afterload, improving the left ventricular ejection. Yes, altered respiratory mechanics and post-pressure ventilation may have a significant influence on hemodynamic after congenital heart surgery. Therefore, the approach to mechanical ventilation should be directed not only at achieving a desired gas exchange, but also at addressing the potential cardiorespiratory interaction of post-pressure ventilation. So this is particularly critical during weaning. So ventilation strategies and approach to extubation for patients requiring long-term ventilation are described in this presentation. But for the majority of patients, getting the tube out of their airway as fast as is safe, the best approach. In fact, many studies document the beneficial of extubation in operation room after pediatric cardiac surgery. Of course, our model is the best ventilation is the one that successfully terminated in the shortest time. Once stable and separated from cardiopulmonary bypass, mechanical ventilation of the uncomplicated patients following surgical repair of a congenital heart defect is not much different than that employed in surgical patients with normal lung. But some patients with borderline cardiac function and residual volume overload may require prolonged mechanical ventilation and a slower weaning process, and it should not be forgotten that mechanical ventilation process is a dynamic process and continued evaluation is necessary. For patients unable to be extubated rapidly either in the operation room or in the ICU, standardization of the mechanical ventilator approach initiated upon admission to the ICU can of value. Standardization of ventilator setting for the majority of patients could then prevent unwarranted utilization of potential harmful ventilator strategies and improve outcomes. In terms of specific management, for example, it's well accepted that a low tidal volume strategy significantly reduces mortality in acute lung injury. Most commonly, tidal volume 6 and 8 milliliter per kilos with ventilation goals of slightly hypercapnia to help induce spontaneous ventilation. PEEP is generally low, 4 and 6 centimeter water, and fractional oxygen is minimized as extubation is expected. So yes, early extubation have a lot of potential advantage. So increased venous return, ventricular filling, and cardiac output in patients with diastolic heart failure. Reduction in ventilation depends nosocomial infection, decreased use of sedative therapy, shortening of intensive care and hospital stay, and cost reduction. Yes, we should plan early extubation. But we should not forget that altered lung mechanics and ventilation perfusion abnormalities are a common problem in the immediate postoperative period. Besides perioperative problems resulting from increased QP-QS ratio, additional consideration include the surgical incision and lung retraction, the exposure to the noxious artificial surface from the cardiopulmonary bypass. Thank you very much, Dr. Dilek and Dr. Tao, and all the connection of the superior. So, both excessive pulmonary blood flow at the expense of the drainage of pleural effusion and acids, thrombosis, of the effective tidal volume mutation, or concerned about low cardiac output syndrome. Great attention should be given to the proper choice of ventilator setting in the patients with an open sternum, as the chest wall and lung have a different compliance profiles compared to those of patients with intact chest. The fact that the lungs are no longer constrained by opposing force from the intact chest wall can lead to significant hyperinflation and polytrium. Those lungs might be able to accept very high and injurious tidal volume while generating only a modest peak inspiratory pressure, which can give the clinicians not preoccupied with the effective inspiratory volume a false sense of security. And patients with open sternotomy wounds require careful monitoring of the effective tidal volume, which is generally set between 8 and 10 milliliter per kilos. Further reduction of tidal volume in these patients might not be beneficial and can lead to the recruitment and atelectasis. The PEEP should be set slightly higher than usual in patients with an open sternum, usually in the range of 5 and 7 centimeter water. This might be necessary to prevent the recruitment of the lung during exhalation when the lung recoil force is no longer opposed in its entirely by the anteriorly open chest wall and could otherwise lead to a functional residual capacity at or below the closing capacity. Another groups, below like 1,000 shunt, other we at the pulmonary banding. There are not so simple palliative procedure, even a complex operation in terms of post-operative management. So small shunt may have a tendency to shunt thrombosis, but large shunt may lead to pulmonary overcirculation and volume loading of the heart. We desire for these patients that saturation should be 75–80%. Extubation is deferred until pulmonary blood flow is adequate and arterial oxygen saturation are stable. If oxygen saturation below desired range is high, we think that hypertension, shunt narrowing or occlusion, lung disease or inadequate shunt size. If oxygen saturation higher 85% and difficult breathing from ventilation, suggestive of pulmonary overcirculation and possible to be shunt. Another group, tetralogy of Fallot, ventriculotomy is important for these patients, so it can cause right ventricular dysfunction. Right ventricular diastolic dysfunction is usually managed with fluids, optimized right ventricular preload, and inotropic agents. At the same time, mechanical ventilation can play a significant role in the clinical course of these patients, as cardiopulmonary interactions can be exuberant in patients with restrictive right ventricular physiology. Patients with normal right ventricular compliance and without residual volume load or pressure load on the ventricular after surgery usually show little change in right ventricular function from the alteration in preload and afterload that occurs with positive pressure ventilation. However, these effects can be magnified in patients with restricted right ventricular physiology or poor diastolic function after congenital heart surgery, especially in neonates who have required a right ventriculotomy for repair of fallotetralogy, pulmonary atresia, truncus arteriosus, and in patients with concentric right ventricular hypertrophy. These patients tend to develop pleural effusion and increase intra-abdominal pressure from acids, which further interfere with respiratory performance. As such, rapid ventilatory weaning and early extubation are usually not a viable option for these patients who tend to have a slower postoperative recovery and longer ICU length of stay than their counterparts without diastolic dysfunction. Mechanical ventilation of these patients should center on optimizing lung volumes after the drainage of pleural effusion and acids, while maintaining low intrathoracic pressure so as not to further impair right ventricular function. Manipulation of cardiopulmonary interaction by means of negative pressure ventilation has been successfully performed in selective patients following fallotetralogy repair and might provide an alternative to increasing cardiac output in patients refractory to more conventional treatment strategy. Then another groups and very important groups, hypoplastic left heart syndrome. Postoperative management of the patients after normal procedure of hypoplastic left heart syndrome is very complicated. It has parallel circulation and the limited reserve of the neonate's single right ventricle. Both excessive pulmonary blood flow at the expense of systemic perfusion and inadequate total cardiac output are common and potentially fatal hemodynamic derangement in the acute postoperative period. The pulmonary and systemic circulation are in parallel with complete mixing with a single ventricle effective supplying both systemic and pulmonary blood flow. Treatment strategies are based on maintaining the balance between pulmonary and systemic blood flow, ideally in room air pH 7.4, partial carbon dioxide 40 mm mercury, partial oxygen 40 mm mercury, mixed venous oxygen saturation 60% in case that the circulation is balanced. So if the patient's oxygen saturation 80%, venous oxygen saturation 60%, and it has normotensive, we think that balanced blood flow and no intervention need. But oxygen saturation higher 90% and the patient has hypertension, we think that increased pulmonary blood flow And so low pulmonary vascular resistance, wide BT shunt, residual arch of friction, and we must to increase pulmonary vascular resistance, control the hyperventilation, low fractional oxygen, inotropic support, and surgical shunt revision. But oxygen saturation lower 75% and the patient has hypertension. We think that low blood flow, so high pulmonary vascular resistance, small thrombosis, BT shunt. And we must to reduce pulmonary vascular resistance, so control the hyperventilation, alkalosis, sedation, higher hematocrit, and surgical intervention. And hypoplastic left syndrome, stage 2 operation, so Glenn shunt. Cava-pulmonary connection, so Glenn shunt involved the connection of the superior vena cava to the pulmonary artery, so that venous return from the upper part of the body is passively directed to the pulmonary circulation and is the sole source of pulmonary blood flow. So, postoperative target for Glenn shunt, early extubation, well-ventilated lung, good saturation, and lower volume rapprochement. And mechanical ventilation can significantly influence pulmonary blood flow after pulmonary anastomosis, so Glenn shunt, due to its effect on pulmonary vascular resistance and cerebral blood flow. Cardiac output depends on passive pulmonary blood flow and is particularly sensitive to change in intrathoracic pressure and pulmonary vascular resistance. Cardiac output increases with lower intrathoracic pressure or lower pulmonary vascular resistance and decrease with higher intrathoracic pressure or higher pulmonary vascular resistance. Positive pressure ventilation in this patient reduces passive pulmonary blood flow. Thus, these patients are generally excellent candidates for early extubation, so oxygen saturation frequently improves after extubation. Mechanical ventilation markedly affects pulmonary blood flow after a Glenn shunt. It creates a very specific physiology in which pulmonary blood flow depends on the resistance of two different vascular beds, the cerebral and pulmonary circulation. So we should pay attention to there is a complex relationship between lung ventilation and positive pressure ventilation and ventilation disorders. Lower ventilation pressure create less barriers to passive pulmonary blood flow through the Glenn anastomosis. Good alveolar ventilation without ventilation disturbance reduces pulmonary vascular resistance. Oxygen, lower carbon dioxide, and nitric oxide reduce pulmonary vascular resistance. Good systemic ventricular function without atrioventricular valve leakage helps to reduce COP and therefore transpulmonary gradient, and good urine output prevents the development of interstitial pulmonary edema. Yes, early extubation should be planned for Glenn, but difficult breathing after extubation is very, very important. So lung edema may be triggered by severe negative intrapulmonary pressure. Adequate breathing, depth, and cough reflex should be carefully evaluated before extubation. If early extubation is not achievable, the postoperative ventilator management strategy aims at promoting pulmonary blood flow and cardiac output by lowering pulmonary vascular resistance and intrathoracic pressure. Multiple ventilator strategies have been evaluated to optimize this physiology. The patient is followed up on CPAP while awake under pseudoanalgesia. And hypoplastic left heart syndrome, stage 3 operation, so Fontan procedure. The Fontan procedure is the last step in the stage repair for palliation of single ventricle physiology. So considering that pulmonary blood flow in patients with Fontan physiology is largely dependent on venous return that is redirected to the pulmonary arteries, spontaneous breathing is the most advantageous form of ventilation in patients after the Fontan procedure. Following a technically successful operation without the occurrence of a low cardiac output state or bleeding, patients can generally be extubated in the operation room or shortly after arrival in the pediatric cardiac intensive care unit. Those who require continued ventilation should have lung inflation optimized by the application adequate PEEP to minimize atelectasis and target the lowest effective mean airway pressure to avoid hyperinflation. In the absence of lung disease of effusion, the PEEP is generally set at 3 cm water and effective tidal volume approximately 8 milliliter per kilos are employed. This setting should be optimized, achieve lung volume close to the functional residual capacity. Ventilation at low lung volumes leads to atelectasis and a subsequent increase in pulmonary vascular resistance. Ventilation at high lung volumes leads to hyperinflation and adversely affects pulmonary blood flow and oxygenation. In Fontan patients who do not meet early extubation criteria, the method of mechanical ventilation requires thoughtful consideration. It should be the lowest possible mean airway pressure, and it has alternative ventilation strategies. So there are high frequency ventilation, negative pressure ventilation. High frequency ventilation for in patients with significant lung damage. It has low tidal volume and higher respiratory rate. Negative pressure ventilation, it's increased in cardiac output, improved hemodynamic status, but it's very, very difficult to apply in cardiac surgery, so edema in the chest wall. So, as a result, the use of optimal ventilator parameters in the setting of invasive ventilation is essential for improving patients' outcome in the intensive care unit. Thank you for your attention.
Thank you.
Thank you very much, Dr. Dilek and Dr.
Thank you. Thank you, Professor Omar. We have a very interesting and very knowledgeable presentation. Now we will have polling question number 2 regarding the arrhythmias, junctional ectopic tachycardia, reduced cardiac output in the post-op period. So this cardioversion is due to stop the cardiac tachycardia. Which do you choose? Is it choose or false? You have 30 seconds. Yeah, the time is up. Wow, we will have 50-50, right? Okay, the right answer is false. You cannot do the cardioversion.
Thank you, Dr. To, and thank you, Dr. Shauluk, for your great presentation. And now I think we will see the answer of this question in the presentation of Professor Canan Ayabakan. I want to introduce our second speaker, Professor Canan Ayabakan. She is professor in pediatric cardiology, working in Acıbadem University. Her interests are congenital heart disease in children and adults, congenital heart echocardiography, fetal echocardiography, non-invasive arrhythmia, cardiac catheterization. Please, Canan Ayabakan, it's your turn now.
Hello, everyone from Turkey, and thank you for the introduction. I would like to thank the organizers for this opportunity. It's a privilege and an honor for me to be a part of this webinar and to talk in front of this audience. And now I will share my presentation with you. I will be talking about arrhythmias in ICU after cardiac surgery. And the outline of my talk will be like this. Usually the tachyarrhythmias are well tolerated by the normal heart, but in the postoperative period, it may cause hemodynamic compromise. It may prolong the stay in the ICU. It may prolong the ventilation time of the patient, and it may also increase the mortality. The ventricular compliance is usually lower after the operation. So AV synchrony is very important in the postoperative period because the atrial contribution to cardiac output is essential. And the postoperative period is a vulnerable period hemodynamically because a lot of changes happen. These changes start in the preoperative period because of the congenital heart disease, and there are effects of the cardiopulmonary bypass, and there is a myocardial injury, tissue hypoxia, scars, and suture lines because of the operation, and there are metabolic and electrolyte disturbances, an increased sympathetic tone, and high catecholamines, usually after the operation, and the catheters that we put in the patient cause increased risk for postoperative arrhythmias. So if we anticipate to diagnose, we can treat early and timely these tachyarrhythmias. So if there are known preoperative arrhythmias, we should be aware of them. And there are certain arrhythmias that are expected in certain type of congenital heart disease, like in Epstein's anomaly, in corrected transposition of the great arteries. Usually supraventricular tachycardias are often. Atrial dilatation, ventricular dysfunction in a patient may cause arrhythmias and increase the risk after operation. And there are some high operative risk factors for arrhythmia. Those are young age and small patient size during the operation, long cardiopulmonary bypass and aortic cross-clamp times, deep hypothermia, complex surgical operations, higher postoperative troponin and lactate levels, higher inotropic score, and hypomagnesemia, usually induced by cardiopulmonary bypass, may increase the risk for tachyarrhythmias, especially junctional ectopic tachycardia. So we should anticipate the potential abnormalities. We should monitor them closely and detect and diagnose rapidly. When the patient comes to the ICU, the first thing that we should do is 12-lead ECG as soon as the patient comes. Even if the patient is in sinus rhythm, it helps us determine the basal QRS morphology of the patient because it may change after operation. If the patient is in arrhythmia, it helps us diagnose the type of the arrhythmia. And we should also check the atrial electrodes if they're working. So we should do an atrial electrogram. Here's a case of a 5-month-old baby with a large VSD. After the operation, the patient was admitted to the ICU with a heart rate of 145, blood pressure and CVP and blood gas analyses were normal. The patient was taking adrenaline, dopamine, and milrinone. And the ECG on the monitor was like this, which was normal sinus rhythms. After 7 hours, the heart rate increased, the blood pressure dropped a little, and the CVP increased. The body temperature was subfebrile and slightly acidotic with slightly increased lactate. The ECG on the monitor was like this. Here, when we printed the ECG, we can see that there's narrow QRSs, it's tachycardia, and we can't observe the P waves very easily. So it's fast rhythm, normal QRS for age. P's are not clearly identified. It's a regular ventricular rate, so it should be either one of these arrhythmias. To differentiate among them, we should record an intracardiac ECG or the atrial electrogram. There are two types of atrial electrograms: unipolar, when you tie the atrial leads, attach the atrial leads to the precordial leads, V1 or V2, for example. Here you can see both the P's and the QRS's at the same time, and you can compare. Or there's a bipolar recording where you attach the atrial leads to the extremity leads. I do not find this very practical because I can't compare the A's and the atrial and the ventricular contractions. I usually do unipolar recording. If we don't have working atrial pace wires, we can always use transesophageal electrodes, and this also provides us atrial signals. We can also do some simple electrophysiological study, and we can do the atrial overdrive pacing. If we don't have either of those, and we can't differentiate atrial and ventricular activities, we can always use adenosine, but we should be ready to pace the patient in case of prolonged AV block, or we should be ready to do cardioversion or defibrillation in case the rhythm degenerates. The adenosine stops reentrant tachyarrhythmias like AVRT and AVNRT by blocking the AV node as part of the circuit, or it blocks AV node and makes the atrial activity more visible, like in fibrillation or flutter, but it doesn't have any effect on junctional ectopic tachycardia or ectopic atrial tachycardia. Here, going back to our patient, this is the ECG of our patient. Looking at the V2 or V1, it's a regular rhythm. There is the P waves are marked with red arrows. There is AV dissociation, as you see. There is no relation between A's and the V's. V's are slightly more than the A's. When these are seen and the QRS is narrow, we diagnose the patient as having junctional ectopic tachycardia. If all these were true, but the QRS's were wide, then we would say that the patient had ventricular tachycardia. Actually, the junctional ectopic tachycardia is the most frequent postoperative arrhythmia. Usually occurs within 48 hours after surgery. It can be seen after any type of surgery, but usually after the manipulation of the junctional tissue. It is resistant to therapy, which is bad, but the good part is it subsides after edema and the inflammatory response to surgery fades away. Usually it takes 8 to 42 hours. So our goal is to slow the junctional rhythm so that AV synchrony is restored with atrial pacing until it spontaneously recovers. We don't always have to convert it to sinus rhythm. To do that, we reduce the inotropic agents. We sedate the patient. Usually dexmedetomidine is a good agent for sedation, and also it decreases the heart rate, junctional rate. Or we can use midazolam or fentanyl as well. Cooling the patient either externally or giving intravenous cold saline helps reduce the heart rate. We should correct metabolic abnormalities, and we can give magnesium sulfate. And if the patient, if the heart rate does not drop below 170, we load amiodarone and start IV infusion Other antiarrhythmics that we could use, procainamide, propafenone, flecainide, or esmolol, are also available. But in our country, usually the only available IV antiarrhythmic is amiodarone and esmolol. Therefore, we always give amiodarone as the first-line drug. The class 1 and class 2 antiarrhythmics have some side effects like hypotension, myocardial depression, QT prolongation, and bronchoconstriction. So we should be careful about those side effects. Once the heart rate drops after below 170, we can overdrive using the epicardial atrial pace wires or transesophageally. If the patient is very unstable, we could always rescue with ECMO, and usually the long-term pharmacotherapy is not needed. The junctional ectopic tachycardia, just like sinus tachycardia and ectopic arterial tachycardia, the mechanism of the tachyarrhythmia is increased automaticity. So just like sinus tachycardia, anything increases the sinus rhythm would also increase junctional ectopic tachycardia as well. Unlike reentry and triggered activity, where overdrive pacing and cardioversion are effective and stops the tachycardia, increased automaticity is not stopped, cannot be converted to sinus rhythm with cardioversion or overdrive pacing. So ectopic atrial tachycardia is very similar to junctional ectopic tachycardia. Either they're in, however, in ectopic atrial tachycardia, there is usually 1-to-1 AV conduction, or there may be AV blocks so that P waves are more than the QRSs. The P axis and the morphology is usually different. The rhythm starts from a different place. And if we give the adenosine, A waves become more apparent, the ectopic A waves. Here is an example of this, where you can see a block here. There are a lot of P waves among the QRSs. Here you can see the blocked A waves. Here it looks like sinus rhythm, but when using the atrial pace wires, you can see that there's 2-to-1 AV block with atrial ectopic tachycardia. Other supraventricular tachycardias are less frequent, usually seen later after congenital heart disease operation, and they are reentrant activity. The mechanism is the reentrant activity, atrial flutter fibrillation, or intraatrial reentrant tachycardia. Usually the A's are more than the V's and the rhythm is irregular, whereas in AVRT and AVNRT, A's equal to V's and the rhythm is usually regular. Here's an example of atrial flutter. Here's an example of AVRT and AVNRT. It is 1-to-1 correspondence in the A's and the V's. We can always differentiate them. If we can't see the atrial waves, we can always differentiate by using adenosine. Ventricular tachycardias are less frequent, usually when there is ventricular dysfunction, ischemia, or hemodynamic abnormality, a ventricular tachycardia may be seen. It is a wide QRS tachycardia with AV dissociation, where the V waves are more than the A waves, as you see here. We always have to treat with cardioversion, because any patient in the ICU with ventricular tachycardia would have a quick compromise of the hemodynamics. We could then use magnesium sulfate, amiodarone, lidocaine, or procainamide to prevent recurrences. Any wide QRS tachycardia should be treated as ventricular tachycardia unless proven otherwise. So our aim should be, in the postoperative period, define the risk factors for preoperative arrhythmias, possibly prevent or treat them early. So we should know the preoperative anatomy, surgical details of the patient, and be expectant of the possible arrhythmias. Have a 12-lead ECG before the operation, and as soon as the patient is accepted to the ICU, and compare them. In the ICU, we should check the pace wires as soon as possible to see if they work or not. We should watch closely for electrolyte acid-base changes and treat in time. And treat hypothermia and fever aggressively in the ICU, and avoid unnecessary long and high doses of inotropic agents for diuretic infusions. Thank you. Hello, everyone.
So thank you, Professor Shana. Arrhythmias is always very complicated topic, as you know, and we can see very interesting that the polling question is 50-50 among our attendees. So Professor Shana, could you talk a little bit more in detail about your polling question? Do you want to talk a little bit about this? Oh, okay. We will talk about later in the Q&A. And please, attendees, if you have any question, please type in the Q&A box, and we will save the discussion to the last. Thank you, Professor Shana. And yeah.
Thank you, Dr. Tao. I think our next question, or yes, please.
Yeah. Now we will have the polling question number 3. Side of the persistent pulmonary hypertension. Include all of the list except number 1, right to left PTA shunting, number 2, right to left foramen oran shunting, number 3, left to right interventricular septum shift, and number 4, tricuspid valve resuscitation. You have 30 seconds. I think the time is up. And you can see the result here. Most of you choose the number 3. It's the left to right interventricular septum shift, which is the right answer, number 3.
Thank you, Dr. Tao, and thank you for Canan Ayabakan's very informative speech. Now, our third speaker is from Ukraine, Professor Denis Surkov. He's the Chief of Service Pediatric Anesthesiology and Intensive Care Unit, working in National Course Director of European Pediatric Advanced Life Support in Ukraine. His interests are neonatal intensive care, pediatric intensive care, pediatric anesthesia, and disaster and emergency medicine. Now, it's your turn, Dr. Surkov, please.
Dear colleagues, my name is Denis Surkov. So today we will briefly speak about persistent pulmonary hypertension of the newborn, which could be like independent syndrome in not cardiac patient, but could complicate some cardiac cases as well. So, successful adaptation to extrauterine life requires a rapid increase in pulmonary blood flow at birth to establish the lungs at the site of gas exchange. And persistent pulmonary hypertension of the newborn is secondary to failure of normal circulatory transition at birth. And it is a syndrome which could be characterized by elevated pulmonary vascular resistance or PVR that cause labile hypoxemia due to decreased pulmonary blood flow and right to left shunting of blood. Pulmonary hypertension with reduced pulmonary blood flow is a normal physiologic state in the fetus because the placenta, not the lungs, serves as the organ of gas exchange. Most of right ventricular output crosses the ductus arteriosus to the aorta, and only approximately 13 to 28% in human fetuses perfuse the fetal lungs due to high PVR. Mechanical factors such as fluid-filled lungs, hypoxic pulmonary vasoconstriction, and circulating vasoconstrictors such as endothelin-1 and products of the prostaglandin pathway like lycopene and thromboxane all play a significant role in maintaining high fetal PVR. And as you can see, in fact, after the delivery, after birth, the fetal circulation should be stopped, and ductus arteriosus and foramen navalis should be closed. But in case of high pressure or high PVR, they remain open, and the persistent pulmonary hypertension of newborn, in fact, this is a case which persists within fetal communications. PPHN can be secondary to lung parenchymal diseases such as meconium aspiration syndrome with or without asphyxia at birth, respiratory distress syndrome, or pneumonia or sepsis, remodeled pulmonary vasculature with normal lung parenchyma, primary or idiopathic, or lung hypoplasia due to oligohydramnionitis or congenital diaphragmatic hernia, or intrinsic obstruction like polycythemia with hyperviscosity. Vascular endothelium release several vasoactive products that play a primary role in cardiopulmonary transition at birth. Pulmonary endothelial nitric oxide production increased markedly at the time of birth. The shear stress that results from increased pulmonary blood flow and increased oxygenation also induces endothelial nitric oxide synthase expression, thus contributing to nitric oxide-mediated pulmonary vasodilation after the birth. Nitric oxide exerts its action through soluble guanylyl cyclase and cyclic guanosine monophosphate. The arachidonic acid prostacyclin pathway also can play an important role. Prostaglandins activate adenylyl cyclase to increase cyclic adenosine monophosphate concentration in vascular smooth muscle cells. Inhibition of prostacyclin production by non-steroidal anti-inflammatory drugs during late pregnancy has been associated as well with PPHN. About etiology and pathology of malignant PPHN. Disruption of normal neonatal circulatory transition due to factors reflects on this picture, results in failure to resolve fetal pulmonary hypertension and leads to the persistence of fetal pulmonary hypertension or PPHN. High PVR decreases the blood flow to the lungs because the blood takes the path of least resistance, which is the systemic circulation. Ventilation to perfusion mismatch and extrapulmonary right to left shunting of the oxygenated blood across the patent foramen ovale and patent ductus arteriosus results in cyanosis. If the PDA is closed and the shunt exclusively is at foramen ovale level, the degree of cyanosis is similar in both the upper and lower limbs. Severe hypoxemia with minimal or no change in ventilator settings or FiO2 concentration is characteristic of PPHN and is due to change in the volume of right to left shunt secondary to subtle changing in the delicate balance between PVR and systemic vascular resistance. Different clinically important conditions associated with PPHN are outlined on this slide, including congenital diaphragmatic hernia, congenital cyanotic heart defects, meconium aspiration syndrome, respiratory distress syndrome, tension pneumothorax, and so on. Diagnosis. In a hypoxemic neonate, differentiating cyanotic congenital heart disease from PPHN is of paramount importance. The initial evaluation should include a thorough history and physical examination, simultaneous measurement of preductal and postductal oxygen saturation, chest radiography, and arterial blood gas test. Preductal and postductal oxygen saturation and PO2 measurements are used to differentiate PPHN from structural heart disease. Saturation differences of greater than 5 to 10% or PO2 difference of 10 to 20 millimeters of mercury between right upper limb and lower limbs are considered significant. And the echocardiography is the gold standard to confirm the diagnosis and to monitor the efficacy of specific therapeutic intervention in PPHN, as well as radiography findings, which could lead clinicians to the right decision about the etiology and pathophysiology of persistent pulmonary hypertension of newborn. Hypoxemia disproportionate to the severity of pericardial disease on chest radiography should suggest idiopathic PPHN or cyanotic heart disease. Measurement of the direction of the ductal and foramen ovale shunt, flattening or left deviation of the interventricular septum, and tricuspid regurgitation velocity on continuous wave Doppler with simultaneous systemic blood pressure measurement provides an indication of right side pressure and hemodynamic physiologic mechanisms. Evaluation of right and left ventricular function will guide the choice of appropriate pulmonary vasodilator. Echocardiographic features of persistent pulmonary hypertension of newborns includes high right ventricular pressure results in tricuspid regurgitation and deviation of the interventricular septum to the left. Assessment of tricuspid regurgitation velocity by continuous wave Doppler is used to calculate systolic pulmonary arterial pressure. The presence of right to left shunt at patent ductus arteriosus is commonly observed in infants with severe PPHN. As you can see on this video and picture, usually we can use the left parasternal short axis view of left ventricle at the level of aortic valve, and you can easily recognize the PDA shunting, which will be founded at the level of pulmonary main pulmonary artery. And you can see that we have the shunt on the on level of PDA. You can see the blue color pattern means that the blood is going out of the ultrasound probe, and it means that in this point you can see the right to left shunt from pulmonary artery to the aorta. This is next slide, which describes how you can evaluate the pulmonary hypertension without Doppler. You can see the same posterior left ventricle short axis view at the level of the aortic valve. And you can see that right ventricle outflow tract is quite dilating. You can compare the diameter of RVOT with cross-section of aorta, and you can see the domination of right chambers of the heart above the left chambers. And if you will see such a video, such a view, sometimes you can make a mistake and you will suggest that you can see the aortic stenosis, but if you will measure the diameter of the aorta at the level of the cross-section of aortic valve, you will understand that the diameter of aorta is absolutely okay, and it looks like the stenotic aorta because the huge dilation of the right ventricle and right atrium. Here you can see the next view. This is so-called design. What it means. At the level of capillary muscle, the same posterior left ventricle short axis view. Usually, you will see that left ventricle will be like a circle, and right ventricle will be like a banana shape. This is because you will see the left ventricle and diastolic pressure and systolic pressure over the right ventricle. In case of PPHN, sometimes you will see that the cross-section of left ventricle will look like English D. What it means that interventricular septum will shift to the left ventricle from the right during the systole of the heart, and it will be equal that the end systolic pressure in the right ventricle is over the end systolic pressure from the left ventricle, but during the diastole, the pressure retains to normal equation, and you will see that the interventricular septum moves during the systole and diastole. If you will see the so-called stable design, it will mean that both end systolic and diastolic pressure are lower in the left ventricle comparing to the right ventricle, and sometimes it will be the same as with PPHN, and you should exclude and avoid of hypovolemia firstly. This is the view of PPHN from the apical four-chamber view, and if you will mistake with your pointer on your ultrasound probe, so you will sometimes you will be thinking that this is like a reversal video of the heart, because you will see the very small left ventricle and highly dilated right ventricle and right atrium. But you can check that, and next you can see at this video, at the center of the video, you can see the left ventricle outflow tract with the beginning of the aorta. Here, this is the ventricle, and you see the moving of the interatrial septum, and here you can see exactly the pulmonary hypertension with diluted and enlarged right ventricle, right atrium, and you can see the insufficiency of tricuspid valve. This is the same view, the same video, but different probe. The previous slide, you saw the cardiac probe or phased array, and here you can see the curvilinear or microconvex probe, and even you can see the left side of the screen inside the heart. You can see the blood flow between right atrium and right ventricle, and you can see the bidirectional blood flow between right chambers, and you can see the huge tricuspid insufficiency, tricuspid valve insufficiency, and huge tricuspid regurgitation. So, depending on the ductal and atrial shunt, we can make a differential diagnosis. Echocardiographic evaluation of neonatal hypoxemia based on ductal, this is black bar, and atrial blue bar shunts. Left to right shunt at the ductal and atrial level is considered normal, but can also be seen in the presence of parenchymal lung disease, resulting in hypoxemia in the absence of PPHNs. You can see that in the lower left quadrant. The presence of right to left shunt at the atrial and ductal levels is associated with PPHN. It describes in the upper right quadrant. Right to left shunt at the ductal level, but left to right shunt at the atrial level is associated with left ventricle dysfunction and ductal dependent systemic circulation, or lower right quadrant picture, and is a contraindication, for example, for inhaled pulmonary vasodilators, such as inhaled nitric oxide. In patients with right side obstruction, for example, such as critical pulmonary stenosis, right atrial blood flows to the left atrium through the foramen ovale. Pulmonary circulation is dependent on left to right shunt and the patent ductus arteriosus, and this is the last upper left quadrant. Management or acute therapy. Management of acute persistent pulmonary hypertension of the newborn, as recommended by American Association of Pediatrics, shown in this figure. First, this is minimal stimulation with the use of eye covers and ear muffs. Sedation and analgesia with narcotic agents and benzodiazepine, and avoiding of muscle paralysis if possible. Maintain of preductal oxygen saturation in the low to mid 90s% and postductal saturation above 70% as long as metabolic acidosis, lactic acidosis, and or oliguria are not present. So we will use so-called permanent or hypoxemia. Lung recruitment with adequate positive and expiratory pressure or mean airway pressure and or surfactant to maintain 8 to 9 rib expansion during inspiration. And finally, maintain adequate blood pressure and avoid supraphysiologic systemic pressure. And so, what should we do if conventional positive pressure ventilation is over? So we can't reach the targeted oxygen saturation, as I told you previously. So we can't reach postductal saturation above 70%, or preductal oxygen saturation above 90s. It means that intra or extrapulmonary chance is over the 50%, so half of the blood which should circulate in the lungs are not oxygenated. Which treatment strategies could be used? Once again, this is temperature control and avoiding of hypothermia. Minimal stimulation, minimum procedures. Don't do a routine lab tests. Avoid intramuscular injections. Even sometimes don't touch these babies. Keep them calm as possible. Sputum aspiration from the trachea should be done like an operation. Sometimes we do that under general anesthesia. Every disconnection of respiratory circuit and endotracheal tube can lead to deep desaturation with very, very long recovery. Morphine with 100 or 100.5 microgram per kilogram per hour loading doses with maintained doses of 10 to 20 microgram per kilo per hour would be used, as well as fentanyl, like monotherapy or combination with morphine to keep this baby in deep analgesic sedation as deep as you can. Once again, muscle relaxants are not recommended. Sometimes prone positioning improves homogeneity of ventilation and oxygenation, and some of these babies feel themselves better in prone position, which could be used up to 16 hours a day. The fluid restriction up to 20 to 40 ml per kilo a day. Sometimes we even stop the basic fluids and just use inotropes, pressors, and so on with fluids for dissolving. This is not so widely used procedure, but there are some publications which say okay for lung lavage with dilute surfactant, which is the ratio between surfactant and normal saline. It depends on specific politics of the institution. We use the ratio 1 to 10, and in different sources, I found the dose of diluted surfactant up to 5 or 6 ml per kilo. We don't use such a big volumes. We use volume on 1.5 ml per kilo of surfactant diluted 1 to 10. Milrinone, this could be like a first line of vasodilators, and it could be used by 50 microgram per kilo of loading doses and 0.4 to 0.5 microgram per kilo per minute maintained. Dobutamine versus dopamine. We use dobutamine because of vasodilation, inhalation, but please be reminded that dobutamine could increase heart rates, and tachycardia is not so good in patients with PPHN. Noradrenaline or non-epinephrine. There are some articles which describes the using of noradrenaline as monotherapy. The goal is to increase the blood pressure in aorta and to keep the aortic or systemic blood pressure over the pulmonary pressure and to reverse the direction of the shunting on levels of PDA or PFO from right to left to the left to right to improve the oxygenation. Magnesium could be used as well, and some articles describes the use of prostaglandins I2, iloprost or ilomedin, comparing with even inhaled nitric oxide, because nitric oxide is quite expensive, and the complications of long using of nitric oxides includes methemoglobinemia and deep tissue tissue hypoxemia. And sildenafil in doses of 0.5 to 2 milligrams per kilo 2 times a day orally is part of our strategy to treat the PPHN. And the therapy of the last chance is VV or VA ECMO based on oxygenation indexes, but this is not the topic of my presentation. So, finally, what we can conclude. After achieving lung recruitment with and without surfactant therapy, further management should be based on oxygenation status, systemic blood pressure, and cardiac and ventricular function on echocardiography. Algorithm showing practical approach to persistent pulmonary hypertension of newborns based on oxygenation, systemic blood pressure, and cardiac function. The management of PPHN has significantly improved during the last 2 decades. The emphasis has shifted from hyperoxygenation, hyperventilation, alkalosis to improved gentle ventilation strategies to optimize lung recruitment and minimize oxygen toxic effects and permissive hypercapnia paired with the therapeutic use of surfactant and inhaled nitric oxide. Thank you for your attention, and I will be honored and glad to answer all the questions you have after that presentations. Thank you.
Thank you, Professor Denisov. We learned a lot from you. And I think that all of the attendees, maybe you will come to see on this video again on the YouTube. We will post it on the YouTube. And now we will come to the Q&A session. We have several questions here for Professor Ulmer. We have a question. The first question, can a specific ventilation mode be preferred for different congenital heart disease or different type of operation? Please, the screen is yours. Professor Ulmer, please turn on your mute.
Sorry, I'm sorry. Yes, it's okay. Yes.
Yeah.
Yes, actually, this is a complicated topic. In fact, there is no definitive mode to use for these patients. Each patient should be individually and the choice should be made accordingly. We use the hemodynamic monitorization and blood gas evaluation also are important in the selection this mode. It's necessary to evaluate the patients separately regardless of their disease. Generally, in the beginning, we prefer SIMV pressure control mode so that we can control pressure, inspiration, time, or volume more easily. Then according to the patients, it can change. Yeah, thank you.
So we still have.
Yes, thank you, Dr. Toran. Thank you. I want to thank to all our speakers. Now, There is a question for Dr. Surkov. I want to ask about your experiences in the usage of surfactant. When should we start the surfactant usage, and can we use the surfactant in all neonates in the treatment of persistent pulmonary hypertension, or should we choose the patients?
Thank you for your question. It will depend on two things. In summary, PPHN will depend on two things: VQ mismatch and PVR to SVR equation. If you clearly understand that this is just newborn, for example, a patient with diaphragmatic hernia or meconium aspiration syndrome as well, for sure, you will need to do the recruitment maneuver. And using the surfactant therapy, it will be much easier. But for example, if you have a patient after cardiac surgery, and this is not just born, a baby, for example, 3-7 days of old or even later, it is a question of decision. Once again, you should check the lungs for if you need to dramatically increase the volume of ventilation or functional residual capacity. And if you understand that you have some situation, for example, I don't know, acidosis, you use high concentration of oxygen for a long time, or patient after operation is cold or something else, and you understand that your surfactant system is in problem, you can use that. But sometimes it works, first of all. Second, I didn't see, if you will do that gently, I didn't see the complications of surfactant therapy. And sometimes the decision could be wrong if you will try to do that. How to manage the surfactant therapy? To use the diluted surfactant or concentrated? Once again, it will depend on the baby's condition. For example, if you have the meconium aspiration syndrome, we usually start with surfactant lavage, and after that, we will use the concentrated surfactant like a continuum of the treatment. You will have the severe respiratory distress syndrome. We will not use the diluted surfactant. We will use the surfactant administration as a normal procedure. But if you understand that the functional residual capacity of your patient is okay, maybe the surfactant therapy will be not indicated, and you will need to go to the PVR to SVR equation and to play with hemodynamic more than with ventilation.
Thank you so much. Because I don't think that so many people have so much experience about the usage of surfactant. Thank you for your very informative speech. And
sometimes in severe cases of PPHN, surfactant administration can reverse the PPHN dramatically, like bam.
Yes, thank you. Thanks so much.
And I think like previously, I still have a burning question for the Professor Shana, because we have very interesting result of the polling that 50-50 of our audience, and arrhythmia is always a very forgetful and complicated problem for the doctor. So Professor Shana, could you please talk a little bit more about why we shouldn't use DC to cardioversion with the junctional ectopic tachycardia?
Yes, thank you, Dr. Tao. That is really very interesting. And maybe we should ask the question again after the presentation. I hope the answer is now clear. We do not use DC cardioversion for junctional tachycardia because it is the mechanism of the tachycardia is increased automaticity, and DC cardioversion or overdrive pacing only is effective on reentrant tachycardias, and junctional ectopic tachycardia is not one of them. It acts like a sinus rhythm. Whenever we do DC cardioversion for a reentry tachycardia, we expect the sinus to come back. So it's just like that. Junctional ectopic tachycardia doesn't go away with DC cardioversion.
Oh, okay, because of the difference of the mechanism.
Yeah.
Yeah. Now I hope that I will not forget it.
Can I ask a question again to Dr. Canan'a Bakan about junctional ectopic tachycardias? We all know that after tetralogy repairment, valve tetralogy repairment, we see much junctional ectopic tachycardias. What is your preference in the treatment of junctional ectopic tachycardia in these cases? Would you prefer using antiarrhythmic agents, or would you prefer to start with, for example, dexmedetomidine? Can you share your experiences about this, please?
Thank you, Dr. Dilek. That's a very good question. Yes, junctional ectopic tachycardia can be seen after tetralogy or follow repair. The way we act for the tachycardia is that all depends on the cardiac output of the patient and the hemodynamics. Of course, starting with sedation is a good way to do it. Dexmedetomidine is a good sedation for those patients. It doesn't lower the blood pressure very much. It sedates the patient, slows the rhythm, but usually it's not. It might not be by itself efficient and enough. We also use hypothermia because when the patient comes from the operating room, usually the patient is hypothermic. As we gradually increase the body temperature, we see that the rhythm or the rate also increases, and we see junctional ectopic tachycardia then. So we immediately lower the body temperature, either by external cooling or giving cool saline, and we also sedate the patient. If we can't lower the rate as much as we want it to be, like below 170, then we start giving antiarrhythmics. Namely, we usually use amiodarone.
Then, for example, if we use preoperatively or perioperative, if we start dexmedetomidine, for example, do you think that it will work better to use in the intensive care units in these patients, maybe for preemptive treatment?
That's very interesting. I haven't come up with such a study. I know that people are using magnesium sulfate or even amiodarone during the cardiopulmonary bypass as they wean from the cardiopulmonary bypass, and they state that the junctional ectopic tachycardia, the incidence is decreased when they use it prophylactically. I think we should study it and see it. I haven't come up with that.
Thank you. Thanks so much.
I see a question from the audience for Professor Ulmer. What is your ventilation strategy for restrictive physiology of the right ventricle after tetralogy surgery?
Thank you very much. Yes, this patient is very, very difficult patients, but it's important that first of all, myocardial stiffness and volume overload to the pulmonary insufficiency make intrathoracic pressure and pulmonary and pressure more important. So the patients have a lot of acids, pleural effusion. So the aim is minimal pressure support need to prevent lead space and maintain adequate oxygenation. And ventilator modes that support spontaneous breathing and early extubation and inhaled nitric oxide may be beneficial, but certainly it's theoretically very basic, but I said that very, very difficult patients, these patients. Yes. Thank you very much.
Yeah, so thank you for your answer. I'm sorry, I still have another question from my colleague. He want to ask you about your strategy to early extubation with the newborn post-operative of the cardiac surgery, both open and closed heart surgery. Could you highlight some keynote that we need to pay attention when we want to early extubation with a newborn?
Yes, newborn patients, very, very difficult patients, especially we generally prefer to open chest the newborn patients. So generally newborn operations is very complicated, very long operations. Then it has very bleeding and unstable hemodynamic for these patients, very important. And we must protect from hyperinflation and avoid trauma for these patients, especially open sternum, open chest patients. So open sternum require very carefully monitorization of the effective tidal volume. We prefer the slightly higher tidal volume, for example, 8 and 10 milliliter per kilos, and for prevent the atelectasis PEEP, we use slightly higher 5 and 7, especially 7 centimeter water for these patients. And if hemodynamic stable for this patient, suddenly we want to close this chest and early extubation.
Yeah,
Thank
it's
you.
really very hard. Yeah, thank you.
Very hardly, very hard.
I think
Dr. Emmer, I want to, yes, I want to ask Dr. Emmer related to this question, because do you prefer, it's because it's very controversial, high PEEP or high tidal volume? Because we know lung protective ventilation is very important, but these patients are very different from usual regular patients, I say. Do you think that instead of high tidal volumes in open chest people, high PEEP is effective, or it will cause also pneumothorax, because these babies are very low weight and it can cause pneumothorax easily?
Yes, it's a very complicated issue, you know that. If you use higher PEEP, maybe you decrease the venous return in heart, but you allow PEEP for these patients. You need you use for atelectasis, the patient has atelectasis. It's very important balance. But generally, for these patients, we use and prefer a slightly higher PEEP and slightly higher tidal volume for these patients. So prevent atelectasis very important, and pneumothorax, we prevent pneumothorax very important, especially newborn patients and sternum open pressure patients, so that slightly higher PEEP and tidal volume together, it's available for these patients.
Thank you. Thanks so much.
And I still have one to ask Professor Omar. I'm sorry. That do you recommend to take the X-ray, the chest X-ray before you extubate the patient? Post-op?
Yes, post-op we use routinely X-ray chest open patients, and we evaluate everything: organ effusion and heart station and endotracheal tube position, and if patients have atelectasis or station, we evaluate with X-ray.
Do you think that the lung ultrasound can cover those problems? The lung ultrasound. Do you think that the lung ultrasound can rule out those problems?
Actually, we use low doses for these patients, especially our radiologist is very difficult and attention for these patients, and lower doses use the X-ray, but we must use and see this X-ray, these patients.
Yeah, thank you.
Thank you.
I want to ask Dr. Surkov, can you please give your opinions about open chest patients? I know that your experience is too much in this field. We want to take your opinions about this in open chest patients, again, high tidal volume and high PEEP. What do you think?
This is very good question. First of all, to prevent air leak syndrome, to prevent pneumothorax, you should use as low tidal volume as you can. And if you are afraid of, for example, a high incidency or high risk of pneumothorax, you should change your ventilation to high frequency ventilation. Because high frequency ventilation, you will provide with very low tidal volume, even lower than dead space ventilation. You can give the patient high MAP with low tidal volume, and you can manage oxygenation and ventilation independently. This is answer number one. If you are not familiar with high frequency ventilation, or for some reasons you don't want to use high frequency ventilation, I don't know what you don't want, so you want to use conventional ventilation. This is as well. Don't be afraid about high PEEP, because the theory that high PEEP level will decrease cardiac return and will decrease cardiac output is controversial, especially if you have the open chest. Because in open chest, you have no restriction of the lungs, and you can do that much more liberal comparing to closed chest. This is one side of the answer. The second side is control your hemodynamic. If you will see that when you adjust your PEEP level, you will see that your cardiac function will be worsening, stop that. But if you will see to the principles of ventilation, the tidal volume will not improve oxygenation. Tidal volume will improve ventilation. And sometimes excessive ventilation will worsen VQ mismatch. And you will reverse, for example, the lung hyperventilation to the phenomenon of ventilation of dead space. And you will have worse oxygenation compared to the low volume. So my answer is the PEEP, if you will need just to reach the oxygenation, you will start with PEEP. And you can easily control that by lung ultrasound and transthoracic echocardiography. If you will be afraid of PEEP adjustment, then you will try to enlarge your tidal volume or change conventional ventilation to high frequency mode.
Thank you so much. Your informative answer. I know this is all of the issues are very controversial, and in intensive care unit, we all managed to try the true treatment for this. Because of this, it was very important for us to take your opinions about these issues. I think we have a lot of another questions, but we have to end the session. Thank you for answering the questions. I see we have already answered all the questions. And I want to thank to all speakers, Dr. Surkov, Dr. Shavluk, and Dr. Ayabakan, and to Dr. Tao, those who participated in this webinar, and for great support to Angela and IT team. We received very valuable information about very important issues, and today we have discussed 3 very crucial issues that are the most controversial in intensive care unit after cardiac surgery. Again, I want to remind that if you would like to listen this webinar again, the recordings will be available in ASPA website, Facebook, and YouTube. I hope all the participants have enjoyed the webinar. And Dr. Tao will give you some information.
I think that ASPA, we try to empowering through education, and we are ASPA is a non-profit organization, so the mission is to foster the highest standard of pediatric anesthesia care in Asia. Hence, we seek your help to donate and help us in our cause. So please, you can scan to donate to help us. It's been help us a lot, and we will spread this. So thank you. We will come back with the challenge in the ICU after the cardiac surgery part 2 in the 9th September. In the SDT time is 5 p.m. You can scan me to register. So please register, and I hope to see you again.
Thank you so much again for your time.
Bye.
See you there.
Thank you.
Bye, everyone. Thank you.
Thank you very much.